So today we're going to give you instructions on how to perform small animal radiography. We have some nice assistants here with us today, as well as this wonderful mannequin who's our very well-behaved dog. So before you get started, there's a couple things you want to observe as far as radiation safety. And you'll notice that I've already put on my gown. This protects the front of me from any scatter radiation. It does not protect the back of me. So I do want to keep the front of me facing towards the machine. I've put on a thyroid collar that protects my thyroid gland from radiation, and I've put on a dosimeter badge. Students don't get assigned dosimeter badges, so you won't have a badge, but we are going to practice correctly as we're practicing. What we're going to be using today is digital radiography. That means that there's a plate embedded in the table. This is our machine up here, so this is actually a radiography unit, so this is what creates the radiation. It has a light here in the center, and so that light helps you with the positioning of your patient. If you push the button here in the center, that light will come on. And then you can collimate, and that is to increase or decrease the area that the radiation is produced over. And so you can actually collimate and you can make that area smaller if you have a small patient, or you can make it larger. Of course, this patient's pretty large, so we're probably going to be on the larger side for a lot of those views. In general, we want to be as far away as possible from that primary beam. We never want to have any of our body parts in that primary beam, even if they're covered with lead. And so that's something to keep in mind as we're positioning. There's a few positioning aids that we may be using today, and some that you should be familiar with. So we do have, this is just a wedge, and that can be used to help position patients. We also have a V-trough, and so this V-trough they come in various sizes, and so for example, a lot of our patients may resent being held on their back, and so some patients will feel much more comfortable if they're put in a V-trough because it feels just a bit more like being in a bed. So if you have a patient who is showing you some signs of distress, it may be that they just want a little bit more padding and a little bit more of a support there. We also have some sandbags of various sizes. If we have a patient who is sedated or anesthetized, using sandbags will actually hold our patient down to the table so that we can actually leave the room to take the radiographs from outside the room. And that, of course, further decreases the radiation exposure that we experience. So whenever possible, if we're able to use those sandbags, that would be our first choice. If we have a patient who's fully awake, they're probably not going to stay down with those sandbags, so we are going to demonstrate how to restrain those patients. We also have some lead gloves here, and these come in sort of various shapes and sizes. They do dramatically decrease your ability to hold on to things. So keep in mind that you can put your hands in them, or potentially you also can lay them over top of your hands, as long as you're covered and you're far enough from that primary beam. So what we're going to do today is we're going to go ahead and get started, and we're going to demonstrate some chest and abdomen films, and then we're going to move on to some common limb views. And so what we do when we position is we're also going to measure this guy, and you don't need to measure him for your labs. I just practiced once or twice so you're a little more familiar with it. But this is basically a centimeter ruler. It has inches on there too, but you're going to be working from centimeters. And so when you're working on your patients, you're going to go ahead and measure them. And the way we do that would be over where the thickest portion of where that primary beam is going, and then we read at the bottom. So this would be 23 centimeters that this dog is thick. And then we have that measurement, and that measurement determines how much radiation, how much kVp and MAS we're going to use for the patient. And so we take that measurement and we go to a technique chart. In this room, the technique chart is here. And the technique chart typically will be different for different areas of the body. And that has to do with particularly that MAS. So in areas where we have a lot of change, so like lungs, we have a lot of motion in lungs, we may use a lower MAS. That way we don't get some motion involved in that, since that is a time-related function. We're not going to have you go ahead and set the machines today, but do practice measuring and make sure you're comfortable with how to do that. So when we start with chest films, there's a couple things to keep in mind when we're radiographing a chest. And the first is that, and it sounds super obvious, is make sure you get the entirety of the lung fields. And so the lung fields extend farther cranially than you think they do in general. And so they're all the way out at the thoracic inlet. So we want to make sure we get far enough cranially. And then of course we want to go caudally to the point that we would get the last rib as well. And then the borders would be, we also want to get in the vertebrae and the sternobra as well. And so we're going to go ahead and radiograph this guy in lateral. And so what we're going to do is we're going to pull his forelimbs forward, and you should be wearing gloves. So you can go ahead and put those on. And so what she's going to do is she's going to pull his forelimbs forward. And what that does is it takes the musculature here of the forelimb and it moves it off of the chest, and it helps with interpretation. All right, you got him? Great. And so here I'm definitely far enough forward. I'm going to get the cranial portion of that lung field, definitely far enough back. I can collimate a little bit because I'm still going to get my sternobra and my vertebra in there. And then this would be the point at which I would go ahead and step on the pedal and take the shot. When it comes time to do our VD view, and we're pretty much always going to do 2 views minimum. Sometimes we may go ahead and choose to do 3 views in these guys. But in this case, we're going to go ahead and do a VD. If you have patients who have particularly cardiac problems or they're having difficulty breathing on their side, you may find that you roll these patients up into dorsal and they immediately actually have a lot more trouble breathing. And so just be aware that you can also do a DV, so put them in sternal, if you have patients that you feel are too unstable to actually roll on their back. But this guy, he's not having any cardiac problems today. We're going to go ahead and roll him up on his back. And again, we're going to extend his forelimbs forward so that that musculature is away from the chest. We're going to extend his hind limbs, and we're going to place his sternum directly over his vertebra so that he's not rotated one direction or the other. And we're going to center that cross right about where his heart is. So I'm actually going to slide back just a little bit. And then we're going to collimate down to just get the area that we're interested in. We'll make sure we get that thoracic inlet so we get those cranial lung fields. The other thing to keep in mind on chest films is that we do want to take them on inspiration. So this patient, not going to inspire anytime soon, so we don't have to worry about that too much. But in our live patients, we're going to wait until they breathe in, and what that does is it expands the lung fields and it helps us to see better definition in the lung fields. If we have a patient who is panting very quickly, we ideally would get them to stop panting before we take those films. So we'll go ahead and take this film, and then we're ready to move on to the abdomen. So let's roll him back. Now he is a very large breed dog, okay? And so when we do an abdomen, we need all the way from the cranial portion of the liver, all the way back to the caudal aspect of the bladder, or if he's an intact male dog, we'll include the prostate in that as well. And so in some of our large breed dogs, that may mean we actually need to take 2 films. We may need to take a cranial abdomen, we may need to take a caudal abdomen, because we don't want to cut off those margins. If we have a dog that's small enough, then we potentially can get those all in one picture, and I think we'll be able to get those all in one picture for him today. So we are going to go ahead and take a lateral radiograph of the abdomen, and so we're going to slide him on the table so that we're coming back to the caudal aspect of the bladder and all the way cranial so that we know we're getting some cranial liver. And because you're farther from the primary beam, I'm going to go ahead and give you some gloves. If we were going to sandbag this shot instead, what we do is we lay a sandbag over the hind limbs, we lay a sandbag over the front limbs, and we lay a sandbag over the neck, is how we would do that. And the same is true for those chest shots too. So probably getting just a little bit wider than what we need on him so we can collimate down. We're going to make sure we get the ventral abdominal wall as well as the vertebra, and then we are ready to go ahead and take this shot. It centers, roughly speaking, on about the middle of the liver to spleen type area. Okay. So once we have a lateral on him, we're also going to take a VD abdomen. And so we're going to go ahead and gently roll him up onto his back. And so similar to the chest view, we want him to be square. And so we want that sternum to be, roughly speaking, right over the vertebra. We want him to be straight up and down. And again, we want to catch the cranial border of the liver and the caudal border of the bladder. And we're going to collimate down as much as possible and still do that. If we were going to sandbag him in dorsal, we would put a sandbag over both hind limbs, usually one on each, and then a sandbag over both forelimbs and one over his neck as well. That would be the same if we were going ahead and sandbagging him while we were radiographing his chest in dorsal as well. So this VD view, go ahead and make sure we're square, there we are, would be our VD abdomen that we would take. Okay. So let's go ahead and move on to our hind limb. and we're going to show you how to radiograph the pelvis and the stifle in the hind end. So those are some of the more common joints that we would tend to radiograph. And so when we go to the pelvis, the problem with the pelvis taken in lateral is if we're perfectly in lateral, the acetabuli lay over top of each other, so you actually can't see one and the other. So what we do is we actually will draw, we put the affected limb down. So if we have, for example, in this dog, if we had a suspicion that the left hind limb was causing him problems and that was our area of interest, we're going to put him left side down on the table. We're going to put his left leg kind of in a neutral position, and then we're going to take his right leg and we're going to go ahead and pull it gently caudally. So we're not aiming to rotate the pelvis. We want to keep the pelvis lateral, but we do want to draw that limb back so that it separates those two acetabuli from each other so that we can distinguish those on the film. And then we need cranially, we need the cranial border of the wing of the ilium. We need all the way back to the ischium on the pelvis, but we can collimate this down a little bit. And then we usually want about half of the femur in that shot, as well as our vertebrae. So this is actually a pretty good place to start with him. So we would go ahead and take this film, and that gets us our lateral. When we do a DV film for our pelvis, this is one of the most common pelvis shots that we'll take, and this is the shot that we take, for example, if you're getting hips OFA certified. This is not an easy view to take, so there is a learning curve, especially with this one. There's a lot of positioning that goes into it. So we're going to go ahead and roll him up on his back. We're going to center him so that the primary beam is basically centered on the tubercocci. And then what we need is we need the cranial border to be all the way at the top of the wing of the ilium. And so his wing of the ilium would be about here. And then we actually need to get all the way down to his stifles. His stifles need to be included. So I'm actually going to slide him a little bit farther. One of the more common mistakes that we have happen here is that we don't get those stifles in the film, and they have to be in that film. And then we want it to be nice and squared. It's easy with them, they get shifty and the pelvis gets rotated a little bit. Ideally we even have the tail straight out behind him too, so it's not laying over anything. And then we're actually going to take the hind limbs and we are going to grasp them and rotate them inward, okay? And so what that does when we rotate them inward is it makes it so that the patellas lay directly over the joints, over the femurs. And so you may want to palpate and make sure that those patellas are right over the joint. So again, to review, you need the entire pelvis, you need all the femur, you need the stifles in as well, you need the patellas rotated so that they're over the femur, and you do that by rotating the hind limbs in, and you have the hind limbs stretched and straight legged, and then you're ready to take your VD pelvis. We'll go ahead and take that view and then move on to some stifles. So once we have these and we go to our stifle, the most common view we're going to take of a stifle is to take a lateral view. And so when we take a lateral view, we're again going to put the affected limb down. So in this case, our region of interest would be our left stifle. And what we're going to do is place that stifle, roughly speaking, at about 90 degrees. And so someone will either need to sandbag or hold this limb, and then we draw the limb that is up, which is in this case the right, back, so that it's separated off of this stifle. And here we can collimate down quite a bit, because really all we need is just that joint. So we're going to slide him, and we might as well decrease the amount of radiation we're exposed to. So when we think we've got that, then we'll go ahead and take that lateral shot. There are some other fancy shots that you can take on stifles. We're just going to have you learn this one for now, but depending on what kind of surgeries you're doing on stifles, you may have very particular views that you need to get prior to going into surgery. If you're using a machine that's not digital, if you're using a plain film machine, you will take any of the views from stifle downward and from elbow downward with the tabletop technique. And what that means is that you'll actually put the plate directly on top of the table and then put the dog's limb on top of the plate and shoot it that way. Because this is digital and the plate is embedded in the table, we're going to shoot all of them without moving the plate on top of the table. So we're going to go ahead and move to the forelimb now. And so when we're working with the forelimb, we're going to show you how to radiograph both the shoulder and the elbow. And so when we do shoulders, there's two views that are commonly done for shoulders. And the first is a lateral. And so again, we're going to have the shoulder of interest is the one that's down. And so we're gonna have that limb kind of in a neutral position, and then we're gonna take the other forelimb and we're gonna kind of rotate it up and away. And so our goal is to get this limb, and I actually go a little bit further, to get this limb so that we're gonna get that shoulder in the view without any portion of the other limb overlaying it. The other thing that can be helpful is to actually draw the head back away from the limb, and the reason is because sometimes the trachea will actually overlie the joint space, and we don't want the trachea to overlie the joint space. So in other words, we don't want to see his head, you know, kind of down by his forelimb. We want to see it well back. And we got that limb rotated away. We can go ahead and narrow this down a little bit. We do want at least half of the humerus in there, but we can make this a much smaller shot potentially. So we'll go ahead and take that view. When we do a lateral on a shoulder, we do roll him up in dorsal. And so when he's in dorsal, we're gonna go ahead and take both of his limbs just like we would have to get a thorax, except in this case, we're focusing just on one side. So we're gonna put that primary beam right at where his shoulder's gonna be, and we're gonna go ahead and take this shot as a VD for the shoulder. When we move on to the elbow, we're gonna roll him back in lateral. So this would be a tabletop technique if we had a machine that wasn't digital. In this case, we're gonna keep going without moving a tray or anything like that. And so we take his elbow, and again, affected side down, we're gonna bend his elbow at about, and we are actually gonna bend his elbow as far as it will. So we do a strong flexion view on these, so fully flexed, and he is not wanting to flex at the elbow today. So we'll lay him down just, there we go. And then we're gonna make that as flexed as that elbow can possibly go. We're gonna collimate down a little bit so we just get the joint of interest, and go ahead and take our elbow fill. Okay, thanks. There are a lot of other parts that you can radiograph. We're also going to have you radiograph one bone of interest as though there was a fracture there. And so you guys may be doing a femur or a tibia or a humerus or a radius. So you'll be assigned one bone of interest as far as a fracture goes. And when you work with that bone of interest, what I want you to keep in mind is two things. First is we do need two views. So we need a lateral, and then typically it's a craniocaudal view as well. So you need two views, and that's so that you can see any displacement of the bone and so forth, and get a three-dimensional view of it in your mind. The other thing that you want to keep in mind is if you're radiographing a long bone, you need to have both the joint above and below in that film. So for example, if I was going to radiograph his humerus, I would need to make sure that in that I included his shoulder as well as his elbow. If I was radiographing his radius, I would need to make sure I got his elbow as well as his carpus. So we'll have you go ahead and radiograph one of those bones as though you had a fracture there. So things to remember as you're working is that we do want to make sure that we're positioning very well. If you poorly position your radiographs, there's no amount of manipulation of the images that is going to get you what you need. So we do want to be very careful in positioning. It's very frustrating for the staff as well as for the animals if you have to keep going back to the table, not to mention the time that's consumed. So taking a little extra time to make sure everything's lined up, making sure you're taking those thorax films on inspiration, abdomen films on expiration, those kinds of things will help to make sure that you're getting good quality views. And then very carefully measuring and setting your machine. We want to be very careful with radiation safety, so we want to make sure that we're wearing all of our lead, we're wearing our dosimeter badges, and that we're using gloves to cover our hands. Never, never should our hands be in that primary beam, even if we're covered with lead. And whenever possible, if we have a very sedate patient like this fellow, we would want to sandbag him as opposed to being in the room and holding those. Anyway, so that gives you a basic start on some of the common radiographic views that we do in the canine. And so happy practicing. We hope you get good at it.